Cystic tumors with enhancing nodule in the temporal lobe or the supratentorial region, PXA and or pilocytic xanthosarcoma and ganglioma, they come together in the differential list. When you mention one of them, you mention the other one because they look similar. Cyst with enhancing nodule, cortically based, they can calcify, and they come in younger patients, young adults or teenagers with refractory epilepsy. They are based in the cortex, as I mentioned. Some references say, oh, PXA, the enhancing nodule, is more towards the cortex, and that it can cause dural reaction. So keep that in mind. Okay, so when you mention them, when you mention one of them in your conclusion, mention the other one. As I said, they come together, they look similar. Neurosurgeons tend to take them out if possible. Metastases. As you know, you never go wrong with metastases. If you're stuck, metastases can always go in the differential list. Some of them, especially bronchogenic carcinoma, they can look like a cyst with enhancing nodule, and they can be anywhere supratentorially or infratentorially. So cyst with enhancing nodule is pilocytic astrocytoma, hemangioblastoma in the posterior cranial fossa, ganglioglioma, PXA, and METs in the supratentorial space. Cortically based lesions, if you remember, we talked about PXA, we talked about ganglio, they come together. Oligodendroglioma, we mentioned it's PXA and then DNET. I ordered them in this specific order for a reason, so we remember them as PDOG, or some people like to call it DOG-P, as long as you remember that the cortically based lesions, they can be grouped together in this mnemonic. DNET is this embryoplastic neuroepithelial tumor. It's usually a child with a drug-resistant seizure. It looks bubbly on T2. It has this specific sign of hyper-intense rim on flare. They can calcify, they can enhance, they don't usually restrict. And it's important to differentiate between a DNET and MVNT, multivaculating neuroepithelial tumor, where it is a subcortical or cortical lesion that does not completely suppress on flare. I'll show you an example in a second. So a DNET, it will look like this, bubbly lesion, usually in the medial aspect of the temporal lobes, and on flare they will have hyper-intense rim. And the mnemonic for you is PDOG. Remember this dog. MVNT, multinodular and vacuolating neuronal tumor, cluster of microcysts, subcortical or juxtacortical, that don't suppress on flare, so they will look hyper-intense on flare, and they are a low-grade tumor. Leave me alone lesions, they call them, or don't touch lesions. They don't do anything.